Hello everyone. Welcome back to a new quick review. We are going to talk about today for hyperthyroidism. This is a high yield topic related to the step 1 and related to the step 2 CK as well. When we are talking to hyperthyroidism, we need to be sure, first of all, how is the complete axis of the regulation from the thyroid. So we are getting from the hypothalamus, the TRH, and after the TRH, that hormone is going to activate the TSH in the pituitary gland, and the TSH is going to activate in the thyroid gland, the T4. And the T4 is going to activate three principal things in our body. That things are the move, the metabolism, and the mental stuff. It's the 3 M's. The move, the metabolism, and the mental things. So we can say that the T4 in the complete axis, the TRH, the TSH, and the T4, we need those hormones to maintain the life. Without the T4, we are not able to continue living. So we need to move, we need the metabolism, and we need the mental things to maintain the life. So if we have any situation that is getting us a high levels of T4, we are going to get a high levels of movement, a high levels of metabolism, and a high levels of the mental things. So when we are getting a hyperthyroidism, we are getting a high levels of T4. So the symptoms that the hyperthyroidism is going to give us related with the movement is increase the heart frequency, the heart rate. That can produce AFib. And we are able to get a diarrhea because the diarrhea is related with the increase of the movement of the gut. Now, when we are getting an increase of the metabolism, we are going to get some symptoms related with the increase of the metabolism, like heat intolerance, like an increase of the deep tendon reflexes, and like a decrease in the weight. Now, the principal diagnosis is through the TSH. And with the free T4. How is going to be the TSH and the free T4 in a patient with the hyperthyroidism? The free T4 is going to be high, excuse me. And remember, the T4 is the hormone that is going to show us the exactly point of the patient. If the patient is through the side of the hyperthyroidism or if the patient is getting through the side of the hypothyroidism. So in this case that we are talking about of the hyperthyroidism, the T4 is going to be high and the TSH is going to be low. Remember that the T4 produces a negative feedback into the TRH. So after we are able to see that the patient is getting a low levels of TSH and is getting a high levels of T4, we need to check the patient with a radioactive iodine uptake. Radioactive iodine uptake. This is a test that is going to show us how many iodine the thyroid gland is able to uptake. So through the radioactive iodine uptake, we are able to identify the different causes of the hyperthyroidism. So we are able to see like 6 different causes of hyperthyroidism. Those 6 causes are the Graves' disease, the thyroiditis, the multinodular goiter, the toxic adenoma, the factitious disorder, and the stroma ovary. So in the Graves' disease, the main problem, the main issue is that the patient is getting some antibodies against the thyroid tissue. And those antibodies is going to produce an extra stimulation in the thyroid tissue. And that extra stimulation is going to produce an increase in the size of the thyroid gland. And at the same time, that increase in the size of the thyroid gland is going to produce increase in the uptake of the radioactive iodine. So this patient, when we try to take the radioactive iodine uptake, is going to show us a big thyroid gland, an increase in the uptake of the radioactive iodine. But all the situation is due to the increase of the antibodies against of the thyroid tissue. And in the thyroiditis, mostly of the time, the thyroiditis is secondary to an infection. So the patient got an infection, and after the infection, the thyroid tissue is going to be inflamed. And that inflammation can produce a rupture in the thyroid tissue. So in the normal condition, the thyroid tissue is like this. And inside of the thyroid tissue, there are a lot of T4. And after the infection, the thyroid tissue can be ruptured. And that produces a lesion that can lead to the patient to release a lot of T4 through the bloodstream. So those little molecule of T4 is going to be released to the bloodstream. And what happened? The patient is going to be through many stages. In the first stage, the patient is going to get a high levels of T4. But after the tissue of the thyroid gland is able to heal, the patient can be in 2 ways. One of those ways could be that the thyroid tissue is going to be healed. So everything is normal after the situation. But in the another situation, the patient can produce a necrosis of the thyroid tissue. At that situation, we call Hashimoto's. At the end, Hashimoto's is the necrosis of the thyroid tissue secondary to an inflammation due to an infection. So in this case of Hashimoto, due to the necrosis of the thyroid tissue, the patient is going to be hypothyroidism. So in the thyroiditis, we can get at different stages in the patient. We can get a stage that could be a hyperthyroidism, another stage that could be a normal levels of T4, and another stage that we are able to find in the patient a stage that is hypothyroidism. Now, the multinodular goiter and toxic adenoma at the end is the same. What is the difference? In the multinodular goiter, we're going to find multiple nodules that are going to produce excess of T4. So, for example, this patient is going to get a nodule here, a nodule here, a nodule here, a nodule here. And those nodules is going to produce T4. But in toxic adenoma, the patient is going to get just one nodule, and that nodule is too big. But that nodule is going to produce as well T4. Now, the excess of T4 is going to produce a hyperthyroidism. And the factitious disorder is the main problem is that the patient probably is a worker of the health. Probably is a worker, probably is a doctor or is a nurse that is getting or that is taking a lot of T4. It's an exogenous intake of T4. And those patients is going to get elevation of the level of T4, but it's because the patient is taking a pills from T4. Probably the patient wants to get a decrease in the weight. And the stroma ovary basically is an ovarian tissue that is producing T4. In those cases, when we are going to evaluate the patient with a radioactive iodine uptake, in this case, the thyroid tissue is going to be cold. It's not going to absorb the iodine because the tissue is getting atrophy. That is a big point for the step 1 and for the step 2 CK. Thank you, everyone, and take care.